Onc Live Insights is a video editorial program produced by Onc Live.
In 2011, we learned that the mTOR inhibitor everolimus improves progression-free survival in pancreatic neuroendocrine tumors, and we also got the data that sunitinib improves progression-free survival. Those data together tell us that mTOR inhibition is effective and angiogenesis inhibition is effective. So a logical question is whether combining mTOR inhibition with angiogenesis inhibition might be more effective as a treatment for patients who have advanced pancreatic neuroendocrine tumors. A recent study called CLGB 80701, which was performed by the Alliance Cooperative Group, looked at exactly that question. And that trial took patients who had advanced pancreatic neuroendocrine tumors and randomized them to receive either treatment with single-agent everolimus or a combination of everolimus and bevacizumab. This was a combination of an mTOR inhibitor together with an angiogenesis inhibitor that had previously been shown to be fairly well tolerated and effective. That study showed really two things. The first is that there was improved progression-free survival associated with the combination therapy. There was also a higher response rate associated with the combination therapy. It wasn't a definitive study. It's what we call a randomized phase 2 study. So the take-home message here is that combining mTOR inhibition with angiogenesis inhibition is probably going to be an effective strategy to treat patients with advanced pancreatic neuroendocrine tumors down the road. And larger studies looking at exactly that question are definitely warranted. Another question in patients who have advanced pancreatic neuroendocrine tumors is, what is the best chemotherapy? If you do decide that tumor shrinkage is your objective, what is the best regimen for those patients? One drug that has been shown to be effective is called temozolomide. It's an oral alkylating agent. We don't yet know the best way to give temozolomide for pancreatic neuroendocrine tumors. There's an ongoing cooperative group study right now that is looking at exactly that question. It's a study in which patients who have advanced pancreatic neuroendocrine tumors are being randomized to receive either temozolomide alone or a combination of temozolomide and capecitabine, a combination that, at least in some preliminary studies, looks like can be quite effective. We hope that the results of that study will be available in the next year or two and provide us some good information on the best regimen to use when we're thinking about chemotherapy for pancreatic neuroendocrine tumors.
The combination of capecitabine and temozolomide is based on preclinical data suggesting that there's a synergy between the two cytotoxic drugs, especially if the fluoropyrimidine capecitabine is given prior to the temozolomide. Whether that's really true or not is hard to say because thus far we have not had any studies comparing combination therapy to monotherapy when it comes to temozolomide. But hopefully upcoming clinical trial will help answer that question to some extent. There are other studies pairing temozolomide with targeted agents such as Avastin, which in one study was associated with a response rate of approximately 33% in a small cohort of patients. There are studies looking at it combined with everolimus, although I think that combination is a little bit tough for patients to tolerate. And there's some indication that temozolomide should be combined with PARP inhibitors. At least it makes sense scientifically because PARP inhibitors can inhibit DNA repair enzymes. There are trials looking at those combinations, but they haven't really been completed yet. So hopefully we'll have some data on that combination sometime in the future.
One area of interest has been in the combination therapy for pancreatic neuroendocrine tumors. One obvious question to ask is whether we should use the combination of a somatostatin analog along with agents such as everolimus. The randomized phase 2 study that was done in this setting is the Cooperative 2 study, where patients receive everolimus with or without pasireotide, which is a different somatostatin analog, a novel one that targets somatostatin receptor 1, 2, 3, and 5. In this study, there were some differences in terms of response rate. However, there was actually no difference observed in progression-free survival. So at least at this time, there's not a evidence for the use of pasireotide, adding pasireotide to everolimus. Whether we should add other SMAS analogs such as octreotide or lanreotide to everolimus remains an unanswered question at the current time point.